So welcome everybody to another one of our noontime Berlin Institute bioethics seminar series luncheons, right? And speakers. It's my great pleasure to introduce a guest today who is fortunately in the U.S. For the year, but not normally in the U.S. Dr. Nikola Biller-Andorno is the director, and I will start with there. She is the founding director of the Institute of Biomedical Ethics at the University of Zurich, which is also designated as a WHO Collaborating Center for Bioethics. She is directing the newly established PhD program in biomedical ethics and law at the University of Zurich, as well as the Center for Ethics at the University of Zurich. Dr. Biller-Andorno is one of the leading scholars in our field. She has training in medicine, but also in philosophy and the social sciences, so she is what we sometimes call a triple threat in terms of her areas of expertise. She has served on many commissions and committees in Europe and around the world. As some of you may know, that she was the president of the International Association of Bioethics from 2009 to 2011. People are fond of counting up contributions to the literature. We stop, I don't know what, 120 plus for Nikola, and she is continuing to publish extensively and widely. This year, the U.S. is very fortunate that she is here as a Harkness Fellow. I don't know how many of you know about the Harkness Fellowship, but it's an absolutely extraordinary opportunity for scholars in English-speaking countries primarily, but not exclusively, to participate in exchanges at senior levels, such as Nikola's, and more junior levels in some cases, to look at questions of health policy that cross national boundaries, as well as in some instances, the ethics issues with regard to healthcare that cross national boundaries. So it's delightful to be able to piggyback on an opportunity that has brought our distinguished colleague to the U.S. Her topic today, and it's the topic of her year of study, is this question of what is an ethical ACO. For those of you who don't know the acronym, you'll learn about it shortly. Please join me very much in welcoming our distinguished guest.
Thanks so much for those kind words. It's a pleasure to be here, and I feel particularly privileged to actually get feedback from such a distinguished audience on my very first explorations into the world of ACOs. I've never talked on ACOs before, so that's a new concept to me, a relatively new concept to me as well. And I'm very much looking forward to our joint exploration over the next hour or so. When I was here talking to several colleagues, the hour before, I was asked, well, why did you choose the topic of ACOs? And as a matter of fact, as a Harkness Fellow, you have to apply and suggest a project. And being from Switzerland, what I had suggested was a project that was entitled "A Tiger with Teeth?" monitoring and evaluating the ethical issues of healthcare reform. And this title spoke to my frustration with the role of ethics that's frequently allocated to ethics when we are discussing health policy issues. An ethicist is usually expected to voice a few grave concerns, speak on a panel, but when it comes to the nitty-gritty stuff, when it comes to the implementation, usually in my experience, ethics vanishes from the table, and then the in-group gets together, mainly that's economists, managers, and they set the conditions, and then when you want to talk about the ethical concerns, often reform has been implemented, you'll be told, well, we don't really have any data on this. And so it's not a relevant concern because we can't really discuss it because we don't have any hard data to work with. So I was thinking, could ethicists really try to venture more into this area of health services research? Could they have more of an impact in how healthcare reforms are actually assessed and evaluated dynamically? So the Harkness Fellowship was really a very good opportunity for me because that brings together health services researchers, health policy makers, economists, etc. So that's a pretty unique opportunity for me to explore those worlds, and I'm fortunate to do this in Boston, actually based at the New England Journal of Medicine, and I'm also having secondary affiliation with the Harvard School of Public Health, with the ethics group there, and with the health policy group as well. So if you approach me about any papers you want to publish in the New England Journal, just talk to me after the break for a little fee. All right. So in the beginning, I had wanted to explore issues that are of particularly important to the current health policy debate in Switzerland, like DRGs or something that's just being introduced in some cantons on a nationwide basis. So the switch, pretty radical switch actually, from fee-for-service in hospitals to prospective payment is something that Switzerland is talking about these days. You've done that decades ago, but as I've learned, it's really just, this is not the whole system. Fee-for-service continues to exist. Another issue that's pretty recent in Switzerland is managed care, and there have been attempts to actually promote managed care. They've failed so far. So the question is, what do we do when trying to actually be more cost efficient but maintain quality? So I think this concept of accountable care organization, and that's what ACO stands for, is an interesting one for Switzerland as well. I'm looking forward to bringing home new insights as to how to resolve this tension between trying to really, not exceed a certain budget and have enough money left for other worthy public goals on the one hand, and really providing very decent care for everyone in terms of health. Now, I think another important thing to mention before I start with my talk is that I'm actually teamed up with Tom Lee, who's my mentor at as part of the Harkness Fellowship. He's the network president of Harkness Healthcare. That's a huge integrated delivery system in Boston, including Mass General, Brigham and Women's Hospital, and a number of other healthcare institutions. And a lot of what I'm saying has actually resulted from the discussion with him, and the part of the incentives is actually something, it's a joint work, so I would just like to give him credit for that. The way I want to go forward, you see this all the time, it's, of course, it's 1 to 5 actually. We'll just briefly discuss what an ACO actually is. The ethical mission of ACOs is something I want to outline as the next step. I'll talk about the key management tools of ACOs, which are aligning incentives and performance measurement. Then I'll just briefly outline what I think are framework conditions for an ethical ACO. And then in the outlook, I'll just briefly touch on some remaining questions. Don't venture to answer them. Don't put them up. So what is an ACO? I don't think I could teach you here what an ACO is, but I just would like to inform you on my understanding of what I've learned about an ACO. And I have to admit that half a year ago I actually had to look this up in Wikipedia. That was my first approach. So here you see it's a healthcare organization characterized by a payment and care delivery model that seeks to tie provider reimbursement to quality metrics and reductions in the total cost of care for an assigned population of patients. And then further below you see the CMS definition, the Centers for Medicare and Medicaid Services, which says an ACO is an organization of healthcare providers that agrees to be accountable for the quality, cost, and overall care of Medicare beneficiaries who are enrolled in the traditional fee-for-service program who are assigned to them. Well, once I delve further into that, looking at the CMS website, there was a lot of talk about coordination of care, patient orientation, patient-centered care, prevention, cost savings, and I even found a little video that explains why this is a great thing, with several managers actually stating why they've joined the league of ACOs. And one of them, for instance, said because from day one he realized it seemed like the right thing to do. So reading this, I thought, well, you can be better and cheaper at the same time. This sounds great. You must have found the magic bullet. Let's get over to the yes and very much how you do it. Then I thought, well, haven't we heard that before? Somehow, a few decades ago, wasn't there a lot of promise of coordination of care, of being more cost efficient? Wasn't it called managed care back then? The paper by Zeke Emanuel, published in JAMA, reassured me that it was something entirely different. It said, well, today we've got more knowledge, we've got more data, more guidelines, more quality metrics, more collaboration, more physician control. So it's something very, very different. I still think it's probably shades of gray what distinguishes an HMO from an ACO. And so I think it might be worthwhile to actually look out for the same traps. So I came with a kind of a skeptical mindset, but it was quite overwhelmed with the positive expectations that are actually associated with ACOs here at this point. It's very much about care redesign, improving value, meaning, improving outcomes for patients while reducing cost. And it's about efficient service delivery, and it's trying to make very clear this is not about the culture of denial that managed care has come to be associated with, at least in certain phases, which was then also related to phenomena such as gatekeeping for patients, a lot of bargaining for physicians who had to struggle with insurances, what was covered, etc. So this is not about restricting access, it's also not restricting choice of providers, but rather on protecting choice. If you want to capture that as the triple aim, as famously captured by Don Berwick, and then promoted by the Institute of Healthcare Improvement, the triple aim says you want to integrate improving the health and patient experience of care, improving the health of populations, and reducing the per capita cost of health care. So these are actually three aims that are usually hard to actually integrate. Now, in further approaching the topic of what an ACO was, reading through some of the literature that's available on the web, I realized, there was one person saying it's like a unicorn. Many people, they all know what it is, but no one has seen one. I felt more like many people have seen one, but no one really knows what it is. So it's really hard to get a handle on what exactly an ACO is. And I think part of that is that many institutions actually have an ACO part to their existence, but also have other parts, like for the Medicare part of your patient population, you'd be an ACO, but you could be a traditional fee-for-service institution for other parts. Also, fee-for-service arrangements can coexist while you are part of this ACO system. So it can be a very complex set of different animals that coexist in the same institution at the same time. Then also there are different ACO models. This is a shared savings program. Currently there are 115, at least that's the information of August 2012. There are 115 institutions enrolled in that program. That means if you spend less money than a preset benchmark, you will share the savings. And the amount you share really depends on also the amount of risk you're willing to take. Piney ACOs, actually those institutions who are further along that road to being an integrative delivery institution, they can also, they have enough capital to actually take that risk and assume those risks. And so they can also have higher sharings, share to a higher extent in the savings. Advanced payment ACOs are just models where the respective institutions are actually being helped by advanced payment to actually enter the system, because that would require a substantial investment in the beginning to actually get this, get the performance measurement running, to actually get the quality programs running that are required to actually be part of an ACO. In total, there are expected savings. If you look at the proposed rules authored by the DHHS back in 2011, there would be, the expected savings in the 3 years to come would be $470 million, so a substantial amount. I think the preliminary data shows, at least for Blue Cross Blue Shield, who has done alternative quality contracts, which is kind of a very similar construct. Data show that there is improvement in quality, and there might even be a little saving, but if this is going to be a sustained effect, no one's quite sure yet. So I think the verdict isn't out yet if this is actually going to save money. So you got ACOs as part of Medicare, but you also have many insurances now entering into very, very similar contracts that have the core features of an ACO. And the core features can be summarized as follows. I'm quoting here from McMillan's paper in 2010. They are provider-led organizations with a strong base of primary care that are collectively accountable for quality and total per capita costs across the full continuum of care, so that's the coordination aspect, for a population of patients. It doesn't specify what population. Secondly, payments linked to quality improvements that also reduce overall costs is a major feature, so incentives. And then reliable and progressively more sophisticated performance measurement to support improvement and to provide confidence that savings are achieved through improvements in care. So not only is this a parallel process, you want to become better and cheaper, you even want to become cheaper by becoming better. So that's, I think, quite remarkable, quite a, optimism in thinking that you can actually become cheaper by improving healthcare. Quite a promise, actually. For me, it was helpful to think of what are ACOs actually the answer to in trying to understand what that construct was. And of course, something that everyone's talking about is the large amount of money that flows into healthcare in the US as elsewhere, but in the US there's a particularly high percentage of the GDPs, more than 17%, actually are dedicated to healthcare. So ACOs are certainly seen as an instrument that might help to contribute to bend the cost curve, at least slow growth. Then another theme that's frequently mentioned is there's a lot of waste, there are a lot of perverse incentives, such as a fee-for-service system that would incentivize people physicians to provide as much care as they can because they're paid for the service they deliver. So we see over-provision in certain areas of healthcare. There is frequently mentioned the problem of fragmentation of the healthcare system, with everyone just seeing they can offer the services they can offer their services to the largest possible extent without actually paying a lot of attention to coordination. And then there are phenomena such as the quality chasm, which has been pointed to by the Institute of Medicine report a number of years ago, just showing how large the disparity in quality actually was over the years. You have excellent quality of care in some places and not so great quality of care in other places. So I think these are some of the challenges that ACOs are trying to address. For me, thinking about why you come up with the answer ACOs to those challenges, I've tried to identify some of the features that I thought were kind of peculiar to the US context. And I think part of that is that a compulsory insurance is actually seen by some as a threat to individual liberty, and it's not such a clear obvious consensus as you would find in Switzerland. I think in Switzerland no one would actually discuss the matter of, should we all have healthcare insurance because no one bothers to think about it. It's just a given. It's something that everyone has. It's natural to have. It's an expense you pay as you pay a tax for your car, whatever. It's something that's just part of the way society is organized. So there's no big discussion on that issue. And also, maybe that's just my perception, but I think that healthcare and your health is pretty much seen as a private matter. And whenever solidarity is mentioned as a term, it's mentioned as something that's to some degree foreign to American culture and some threat somehow. And I think healthcare would be understood quite naturally in Switzerland as something that's a matter of public concern. I think there are other areas where the Swiss would be more holding back, like if you want to raise a child, and would you raise your child well, and need an institution to take care of it during the day, that's then considered as a private matter. So I'm not saying everything's perfect in Switzerland, but I think as far as health and healthcare is concerned, people would think that's a matter where we all have to actually pool our resources to make sure everyone's well off. And if you have a population where everyone actually has insurance, you've got this kind of sense of entitlement. And you also got the sense of, if we pay our healthcare institutions, our public institutions, we also want them not to waste our money because it will immediately be felt by those who have the insurance who have to pay more, who experience the rising fees, the monthly premiums. So I think you have you have this kind of check of public opinion on, is the healthcare system becoming too costly? Maybe this contributes also to the slower growth rate as compared to the US. Also peculiar, I thought, was was the reliance on market mechanisms and trying not to avoid top-down approaches. I think in Switzerland, for instance, there is a list of hospitals per canton, and it's quite, it's a received notion that the government of each canton would decide on what the hospital list would look like. So certain hospitals might not find themselves on the list, which is a very much top-down approach to things. So there is like state planning and how many hospitals do we need, what do we need to close, what do we need to fuse. And my sense from exploring the environment here is more that this is something that would be quite difficult to implement. So ACOs, I think, are a very promising approach in the specific US context. Now, if you look at the mission of ACOs, I think that's a pretty clear case. If you tell an ethicist, what if you could respond to health needs of populations better? What if you could continuously improve outcomes that matter to patients while increasing efficiency? What if you could promote stewardship of scarce public resources? I think everyone would say, well, that's great, go for it. That's, that's exactly what we need. So I think the mission, the aims, this triple aim of ACOs is certainly something that's not, cannot really be disputed from an ethicist's point of view. But if you then look at those three missions, you'll see they each raise questions. And I'll go through these three aims, each one by one. The first one, which I've here raised, responding to health needs of populations. I have a fellow Harkness colleague who's also a Harkness fellow, and he did a little qualitative survey involving certain stakeholders and what is meant by actually, addressing the population health component. And the result was that no one quite knows. There's a variety of opinion of what that's supposed to mean. You may want to watch out for Viewpoint in German that's due out this month, so a little advertisement for this fellow. And I think that's an interesting finding that the population component is one of the key aims of the ACOs. But what population? What is that? What does that actually oblige an ACO to do is less far from clear, not so clear. Now, if you look at populations, you can think of different populations. You can think of the population that a hospital conceives of as, its assigned population or self-assigned population. And then I think responding to the needs of that population that you already serve raises questions of, if you want to increase your efficiency, you want to increase your quality, aren't you going to somehow treat certain populations or approach certain patients more intensely than you would others? Are you going to work with your patients differently? Whenever I raised the question about cherry picking, people usually told me, oh no, there's no cherry picking. Of course not. Very clear, no. We don't, we treat every patient who comes into our door the same. There's no problem at all. But I'm just wondering if you, for instance, a physician who's practicing in a certain, in a group practice environment, your institution has become an ACO, you are actually, incentivized to reach certain quality measures in a certain, glucose levels for your diabetic patients for a certain part of your population. Aren't you going to invest your time where you think you can turn patients around and actually increase the, the percentage of patients who, can meet that target? And if you have certain patients who might most profit actually from your working with them, but are not so likely to actually make the threshold because they're not very compliant, because they have lots of other problems going on, because they can't really focus so much on their diet and all those reasons, aren't you going to rather avoid them because you think maybe it's not worth, my investing so much energy and time and my resources in those patients? So I think there might be subtle effects, that might actually lead people to, even if it's not, explicit cherry picking, to focus more on some patient populations over another. I'm not saying you can, in principle, avoid that problem. I think it's probably inherent in whatever system you got, but I think you really have to be very aware of this happening. And this is where I think monitoring would again come in, because usually physicians, when you talk to them, are very aware of who the patients are that they tend to avoid, or patients that tend to be underserved. So I think that's very important information to actually get to. Then if you look at the usual population of a hospital, then I think once a hospital or a system has become an ACO, the question is, if you want to serve the needs of a population, what about your geographic population? In Boston, the ACO, I've come to know a little better, Partners Healthcare, which includes Mass General, Brigham Young, as I said, is very much thinking of itself as a research institution. So what about then the populations right in downtown Boston who are not so arguably privileged and who would certainly benefit from, attention, more attention being paid to them or from more outreach. So I think if you define health, improved health of populations, you might also want to think of an obligation of actually reaching out and extending your own mandate and actually trying to think of what can your institution actually contribute to the health of the population, the regional population. And I understand that might be very different for institutions. Some institutions, a hospital might be specialized in doing hip replacements, and there might be limitations to what they can do to the general public health there, but you might still want to think if you can't stretch your organization's limits in a way that makes it more responsive to the health needs of your geographic population. And then I think another challenge is we all know, with the increased focus on social determinants of health, how healthcare is not, health status is not decided necessarily by access to healthcare. So how can you actually promote a cross-sectoral approach to public health? How could you actually make sure there isn't just a focus on giving people access to healthcare, but neglecting other very salient issues or features of their daily lives that would at least as much contribute to their health? I think the second aim is clearer: continuously improve outcomes that matter to patients while increasing efficiency. I think this is mainly a matter of how do you know what outcomes matter to patients. And now a lot of research has been done over the past years. This is really an area that has taken up. I think it's also a matter of how do you actually make sure this is a priority in your institution, because it's easily said that we want to focus on patient outcomes that matter to patients, but then actually getting to those priorities is cumbersome and can be costly. While being in Boston, I've witnessed a few elements which I thought were interesting. I'm sure in this room we could share many more examples of how you can engage patients and families. The examples that I've come across are, for instance, a bereavement survey that was being carried out at Partners Healthcare, and trying to find out, asking families or relatives of someone who deceased in the hospital about this experience and what could be done to improve, etc., etc. So, venturing into a very sensitive area, an area that's even complicated in terms of research ethics. To get a study approved of that sort is also already a complication. So I think this shows some real commitment to actually really explore relatives' experience, and the results of this are then flowing into an end-of-life report card. That means that the continuous monitoring of the quality of end-of-life care provided at that institution. Another element of engaging family is family participation in rounds. Again, something that can be uncomfortable. Again, something that can, mean you have to spend more time. You have to prepare better, do more thinking about certain things. So something that's certainly also something in which you need to invest if you want to do it well. Open notes is another buzzword around in Partners, trying to actually make notes, physician notes, accessible to all patients, so you could just check on, the note that your physician has written about you online, which again raises questions about how do you phrase your notes, what comments do you write in there, how do you work with your patient, but it might also improve quality. And for instance, you have a patient pointing you to certain errors and saying, well, this lab result looks really odd to me, and could we look at this a second? Then PROMs, patient-reported outcome measures, are something that when I talk to my mentor about, he says, well, I'm sure that's really great, but at the same time he sighs and says it's really costly, it's really time-consuming, it's really complicated. But the idea is to actually really ask patients for a certain area, certain condition they might have, what would be really important outcomes for them, and really getting these measures, the points the patient mentioned as really important, and then integrate it into their monitoring system. And then I think another interesting approach is making sure that those, that patient orientation isn't just being paid lip service to as being, the mission of the house or whatever, saying we want to be really patient-oriented, but actually using that also as a basis of individual performance evaluation, for instance. I'll come back later to that point in a moment. Well, now the third aim, stewardship of scarce resources. Coming from Europe, I was allowed to ask some questions. So I asked them, well, what happens to savings? And that irritated some people because they felt, well, it doesn't matter what happens to savings because it's only part of the savings anyway. And the other part then, remains with Medicare. So we've already contributed to savings, so what else do you want? So is that an issue that an ethicist should be concerned about? I think we should be concerned about that because after all, the whole approach was, the idea was to save as much money as we can to make sure more people can benefit from the healthcare system, to save money for improving access to many people. So if you just use your savings to increase shareholder value, for instance, I think that's probably was not the point of the healthcare reform. But then, even if you exclude that, you have other questions. For instance, at a very research-intense institution, you may ask, well, are we going to invest our savings maybe rather in research and in improving our services because we want to maintain our status as a great research institution, we want to be able to retain our top talent, etc. I think, the bottom line is that you really want to, I would like to argue, you need to reinvest, the savings into working towards the goal of improved individual care and improved population care. And for instance, a way to actually improve, increase the mandate, or the original patient segment you serve could be to use actually those savings to actually reach out to your local populations and improve healthcare or contribute to improvement of their health status. Another question I think is how is efficiency actually being increased? One way is just reducing waste, reducing people just standing around and being disorganized and losing time by just not talking to each other. Another approach is actually what's called in Switzerland, I don't know if you even use this here, squeezing the lemon. So you increase density of work, really make sure people work hard. And that, can border on actually impacting, if not on quality, then on job satisfaction or, the way medicine is practiced. I'm thinking, for instance, of if you want to really be more efficient, serve your population more efficiently, for instance, in nursing homes, one way to do that would, of course, be sedation of patients. That's way more efficient, having to deal with confused patients who might be upset or react in certain ways. But then again, and it might even show up in quality, questionnaires. I think the relatives will be as happy, or it might not actually be part of the hard data, but still you'd lose out something in this attempt to actually increase efficiency. Or another example would be this economic approach of actually measuring the time units you need for each part of your treatment. It's called TDABC, I've come to know as an ethicist. And so you ask someone who, for instance, puts on a cast, how long do you need to actually prepare the materials for the cast? So that would be about 4 minutes. How long does it take to put the cast on? So that would be about 3.5 minutes, etc., etc. The question is just, then you end up with a benchmark of the time you should actually need to do this. So the question is, once you've got a screaming child or an upset relative or whatever, you got this benchmark in your neck and actually having to try to be as fast as you can. The question is, how much does this actually pressure you to get through with your things in these attempts to be more efficient? And I think these are effects that are not going to show up in the readmission rate. They're not going to show up anywhere, but it's going to affect the work environment and the climate of how you work. So I think increasing efficiency is great, but just this label of efficiency can just really comprise very, very different things that might be more or less questionable. And then, of course, you've got cost shifting, which is very popular, particularly if you can shift it to private caregivers, like, the mother's at home, or whoever is at home taking care of the patient who's leaving the hospital earlier, or who's usually not going to complain about these tasks. Also, just focusing on a certain patient population helps in kind of reducing the effort you have to put into working with these patients. So you can increase efficiency in very different ways, and sometimes you do have a trade-off. If you really look at cost, a genuine cost, not just to your institution, but overall, and the same is true for quality, which can be effective. Now just an exploration of the key management tools, that is incentives and performance management. Now, if you talk about incentives as an ethicist, you are usually supposed, I guess, to react to something, with saying, well, that's something we should avoid at all costs. There's a certain yuck factor to incentives because they are perceived as something that might lead to the deprofessionalization of medicine, something that undermines, the professional standing of a physician. If you're telling if you do right, he will pay you a little extra because you'd actually suppose that all members of the profession actually aim to do right if they don't even manage to do right all the time. But I think we have to kind of adopt a slightly different perspective from that. And I think wherever you go and whenever you have a payment system, there will be incentives. Whatever way you carve out the budget or however you pay, you'll be incentivized to strictly, remain within this budget, or you'll maybe know you can also exceed the budget. Nothing's bad going to happen to you. Whatever you do, your decisions are always going to be influenced by certain sets of incentives. So I think we cannot actually avoid incentives, but we have to make sure they don't have unwanted effects. There are two main concerns about incentives. One is they're ineffective and irritating. I think certain incentives certainly are. And they can undermine professional ethos. Whenever I was exchanging about incentives with my colleagues at work, they would say, well, what do you think about pay for performance? And I thought, well, I don't really think about incentives as, being just pay for performance. I don't even know if pay for performance is the core part of incentives, because as far as the literature shows, that pay for performance is not hugely effective. So I think when we're thinking about incentives, we actually have to think about a broader range of possible factors, such as just the sense of being part of an in-group. You think you're a young assistant physician in a major, research institution. If you are publishing a good paper, this is hugely going to increase your status in this group. You feel you're part of this, prestigious institution. It's going to strongly incentivize you to actually try to publish more. The sense of appreciation once you get patted on the shoulder for doing something, or scolded for not doing something, or vice versa. I think these are very important and strong incentives or disincentives to do certain things. Once you got shamed in a clinical conference in the morning because you're an outlier on a certain, in terms of utilization of a certain, let's say, imaging technique that's costly, you might very carefully consider if you're going to send your next patient to this kind of imaging. Of course, it's the effect, the intended effect, but that's a very strong disincentive to do something. It might be way stronger than knowing you're going to get a little extra at the end of the month. A third part is then social, increase in social and economic status. So I think pay for performance is certainly part, but I think it's just a part. And then I think a fourth component that's not frequently mentioned is the resonance with your individual goals and values. And I think this idea of actually being able to feel proud of the work you do, particularly after a certain amount of time, can be a very strong incentive to actually keep up certain work and continue doing it. Now, I think this fourth component that I've just mentioned, this kind of shared vision, is an institution able to actually create a sense of, we all own this kind of vision, the aims, etc., is a major basis for ethical incentives. I think once you got healthcare professionals' consent and actually wanting to steer in a certain direction, you can then justify certain mechanisms or strategies that you employ to actually get there. But I think what's only bad is if you try to manipulate professionals into something that's actually against, leads them to do something that's against their own better judgment. So I think this needs to be done as a two-way street. Healthcare professionals shouldn't just be graded or or rewarded based on certain actions, but they should be able or expected to engage in the development of the scheme and the continuous evaluation of that scheme. I also think that all incentives arrangements need to be continuously assessed in terms of what do they do with quality, efficiency, and equity of patient care. And also, I think what is important and frequently not actually sought out is how do healthcare professionals actually perceive those schemes? Do they create new conflicts of interest? Do they create moral distress? Do they crowd out internal motivation? Because if you talk to physicians, at least that's my experience, they will tell you. If you talk to nurses, they will tell you. The question is, do you bother to actually systematically ask them and get their feedback? And I think that would be a very important feature of incentive schemes. The second element is performance measurement. That's getting a sense of reporting on the quality that your institution provides. There are two sides to this. One is individual performance measurement, where you just you work with individuals. And I think what is an interesting approach here is to actually try to, if you want to be really patient-oriented, if you want to be responsive to population health needs, to really rather immediately build this into individual performance measurement and see how individuals actually contribute to that goal. I think that's an interesting approach. A second one is to reward physicians not just for obtaining certain measures, but for critically engaging in outcomes measurement. So someone who really wants to improve your institution's outcome measurement should actually, I think, get recognition for doing so. The other part of performance measurement then is the institutional performance measurement. How does the institution overall actually fare on certain parameters? There is a standard quality measurement scheme that's required by the CMS. It's about 30 items. When I looked at it, I know there was a whole debate on how to reduce those items, boil them down to the essentials. But if you look at the aims and compare them to what is being asked, I'm always disappointed in how far you can get. Like responsiveness to health needs of the population is then boiled down to screening, vaccination, and these kind of issues that I think if you look at public health and the social determinants of health aren't really where I think the biggies really are. So what we would like to do, and that's going to be part of my work over the next remaining months here in the ES, is to try to build on what's been done, the work that's been done regarding errors in patient treatment, and the safety culture that's been developed, not just measuring or following up on errors, but also trying to build a culture around that. How do we deal with errors? How can we create a culture where people can actually talk about them? How can we create suitable feedback loops? And I think we need something parallel for, errors in judgment made with regard to patient care based on certain incentive schemes, for instance, conflicts of interest, etc., as kind of a sentinel function to actually alert hospital management and the physicians working and healthcare professionals more generally working in institutions where things might be going wrong. And this is, I think, where we're going to focus on in the next months. Now, just briefly, resuming what I think are framework conditions for what might be called an ethical ACO. And I've chosen this question, what is an ethical ACO, being prompted by, Tom Lee, who told me as a manager, I want to do good while doing well, so tell me what would an ethical ACO look like. So this is where I stand. After my few months of exploration, I'd say you need a mission that healthcare professionals can identify with. So you have a basis for a shared vision you can actually communicate talk about within your institution. You need to be transparent about your institutional aims. You need to know what population you serve and why, and also the way they are promoted. I think you need to build something like an ethics culture, which is a climate of respectful social interactions. And blaming and shaming, something you use to make sure physicians or healthcare professionals act in a certain way, certainly couldn't be part of that. And saying you have again used such and such a number of interventions, and here you are, and now we'll put this up on the hall in the way so everyone can see it. The bad results that you've received. I think that's not compatible with an ethics culture. I think you need to make sure incentives are well aligned so they do not introduce new conflicts of interest, but rather remove existing ones. I think you need to make sure performance evaluation actually resonates with the institutional aims. And incentives and performance evaluation schemes on the quality and fairness of patient care, and also include the perceptions of the people who are actually working under that such schemes. Not just by the way of an outlook, what I still don't understand is how you would get from a volume-driven to a value-driven healthcare if it's still so important for an institution to fare well, have a lot of patients, have a lot of clout in the market. And I don't quite see how ACOs by themselves are going to overcome that. And in particular, when you still have a fee-for-service system in parallel, I'm not quite sure how you would ever get, would circumvent the problem of over-provision for certain lucrative patient segments. As someone from Europe, I'm not so quite sure I understand how you orchestrate this kind of healthcare system, how you make sure it responds to the health needs of an entire population. If it's really market-driven, you go into the sector that's most lucrative in a way. How can you overcome institutional self-interest? I think bundling is a way to go there, trying to force people to have a joint financial interest and trying to force collaboration that way. But from what I've been told, bundling is really complicated and there's certain limits to it. And there are at least so many bundles you can actually negotiate, so there might be certain limits to that as well. And how can you actually foster, and that's something I think that no one has figured out, be it in America or somewhere else, cross-sectoral collaboration or coordination of social institutions, so not just healthcare, to really focus on particularly disadvantaged populations' health status. How can you really genuinely work together in promoting the health of a person who is working double shifts, who's worried now has concerns about maybe not being able to live in the house any longer because of high mortgages, all these kind of social issues that impact on the health of a person. So how can you have a public health approach that actually makes sense in such a setting? All right, I think with these kind of issues, I'll close. I'd just like to thank you for your attention. I'll say Ruth and Jeff have already been to Zurich. We expected all of you to come to Zurich at some point. We'll be more than happy to welcome you there. Thank you.
This is our convention. The floor is open now for about 10 or 15 minutes of questions.
Hi. I have a rather long-winded question, but I'd like to preface it. My name is Jeff Kaplan. I'm an internist in private practice. I live in the city of Baltimore, but I practice in Howard County. And as an introduction, I was born and grew up in Geneva. My father worked for the World Health Organization, and he had his medical cares taken care of. And I remember when he was hospitalized at the Hôpital Cantonal, he had spinal stenosis operated on. He was hospitalized for 3 weeks. Here, he'd be out in 3 days. So there were some perhaps perverse incentives for allowing somebody to stay in the hospital. I think it probably was prolonged. And in that fee-for-service environment, questions are being asked, and certainly it would seem that the system in hospitals would be something that maybe should think about DRGs. And that's part of it. But my thoughts are mainly in looking at the comparison of the Swiss system and the American system. You have two capitalist societies. Both are very market-driven, but the big difference is over there, in Switzerland, health care is a right, not a privilege. In America, and in presenting this talk, I think you're being way too kind and polite to your audience. American healthcare is really totally fragmented and quite shambolic and extremely expensive. So the other comparison is you have the two most expensive systems in the world with outcomes that are very different. And so you're left with trying to figure out how you can provide healthcare ethically. I am constantly challenged. And one of the main reasons is that some of my patients, all my patients have different benefits paid by their insurance. I have to make decisions, medical decisions, based on their economics. Instead of having a uniform benefits, I have to then make financial, and this is for middle class and upper middle class, because of all the different types of insurance out there. And I don't know if that same thing is presented in Switzerland, but certainly here with healthcare becoming much more expensive, increasingly unaffordable, and definitely not universal. We have major problems ahead of us. But a couple of things I'd like to highlight. I'm an internist in private
I'm sorry, we
practice.
just need to get a couple more questions in.
Sure.
If you could just get to your...
And one of the challenges is the separation between a hospital-based system like Hopkins and primary care. So what now happens is, because in the interest of reducing costs, they're suddenly drawing internal medicine into trying to foster and control costs, whereas before, and in America, primary care is not really well respected. And we have to try and look at that in terms of what's happening in the training. And the training of primary care doctors now is no longer going to be in hospitals. It's going to be more office-based, which is what the system is mainly in Switzerland. So my question is if you're trying to find a system that does bridge, you're now actually going much more to an English system where there's a complete separation between primary care and hospital-based care. And so these ACOs, what I've seen, and I'm on the board of the State Medical Society, and we're looking at ACOs. What we've seen is quite simply, there really isn't that much of a connection that really is clear between hospital-based care and office-based care.
Thank you. That's great. Can we just stop there, because that's about 20 things that we could get Nikola to respond to.
Go right ahead.
So thank you so much. Nikola, please.
Maybe just a brief comment. One question you asked about, do we have a uniform benefit package in Switzerland? Yes, there is. There's a well-defined and very comprehensive benefit package that everyone gets. And if you can't pay the premium, you receive subsidies from the state. So everyone is actually covered. And of course, what I presented now is trying to get it into the kind of the cultural context of the US right now, and to appreciate solutions that have been put forward based on the status quo. Because I could also come and say, well, why did you all get a comprehensive benefit package for everyone, pay for it, and then everyone would be, would have their ticket into healthcare. But this is not, it seems to me, saying that would not be really a real constructive contribution to the situation as it is right now, because it's so hard to get through politically.
So on the point about whether ACOs are an effective bridge between the primary care context and hospital-based care, how do you see that or not? And then we'll go to
I think it certainly sets an incentive to do so. And what I've seen is that institutions try to make sure they include all different services, so they don't miss out on certain points, and they have all all different services part of one system. They can actually kind of try to coach towards the way of being efficient and delivering high quality they want. And that's probably part of the concern, that then you end up with this large conglomerates of healthcare systems that will then of course have much more leverage in negotiating with.
Thanks for your presentation. I also think in relation to the question about hospitals and versus physician groups is that empirically it seems like there are increasing numbers of outpatient-only groups that are forming ACOs, so not involving a hospital, and it could be that time will tell what happens in regards to whether hospitals and groups actually align or not. But my question is related to the stewardship aspect of your talk and the idea of what an ACO does with its savings. My understanding is that when an ACO applies to CMS or contracts with CMS, they have to state what they're going to do with the savings, and that those statements are publicly available. Do you know if anyone has looked at them? I think there are now 400 ACOs under CMS. Do you know if anyone has looked at them sort of qualitatively to see what ACOs are doing, or at least saying they're going to do with the savings?
I'm not aware of such a study, but I think that's a brilliant idea. So I think that would be a really cool paper.
Let me just see if there are any other questions, and then we'll come back to you, just to make sure. Are there other questions? Then please.
Oh, good. Thanks. A follow-up question is that, well, obviously, we'd like to see perhaps some place like Hopkins have an ACO, but I haven't heard of one. And it's a bit of a shame, since the health statistics surrounding this wonderful, world-renowned hospital are really pretty appalling. And so it would be hoped that someplace like Hopkins could actually have a system that actually works in the areas surrounding it. So that brings my other question, is that in American public health, there has been a rather marked avoidance of issues based on socioeconomics. People talk about race as a proxy. However, that's not adequate. And And so if we are going to be able to really have a system that does respond to the health needs of its population, it has to do with finding out not just where healthcare is not being delivered, but also looking at the socioeconomic status. Because if you do not take care of that variable, you cannot really decide if healthcare is being adequately delivered. Because my unfortunate poor, near poor, far poor patients are much less likely to be able to understand what I do, and therefore they need more resources. There's no way in this system that we can clearly allocate more resources to people in lower socioeconomic classes. And I'd like to see that those analyses made. Public health doesn't do that.
Yeah, I can
Let alone associate with the payers who can then allocate the money to the areas that need it.
Yeah, I can maybe share with you my first impression when I came here, and I also looked at work done by the Commonwealth Fund. It also included, categories of race, different races and ethnic groups, but not so much the socioeconomic status. And back then I asked, why would you actually, if that's actually just a label, a polite or political label for different socioeconomic classes, why don't you address the issue, even at a place where there's a lot of commitment for improving healthcare for everyone? And I was surprised because I thought that these categories didn't really exist so clearly any longer. I thought, it wasn't so longer so clear who's black, who's Hispanic, because you have such a, diverse society with so many people being part of different communities. So I just share your, feeling awkward with, the continued use of just those categories. They might be relevant for historic reasons. You might have a special focus in certain communities, make sure everyone gets what they are entitled to, but just not looking at the socioeconomic part is certainly, not as good.
So, I'm going to ask a question. I'm going to take the prerogative. When you talk about borrowing on the concept of the safety culture to go to the ethics culture, which I get completely in terms of the success of the safety culture in many institutions, what response have you gotten when you tried that out from your colleagues who don't come from an ethics or bioethics standpoint?
Actually, we've got met with quite a bit of openness to that idea. And I think, if you look at this from a healthcare manager's point of view, it's a good selling point. If you say we promote the ethics culture in our institution, our people dare to speak up if there's a problem. I think the safety culture also kind of partly at least owed its success to its being, good business strategy to say if we have an error occurring, we need to make sure we've got good ways of responding to that. So I think it can be aligned with, what makes a good business case, which I've learned is really important in, making things work. So I'm quite optimistic and that we can push it a lot further.
Well, this was wonderful. Thank you so much. Thank you for coming.